Hello, everyone, dear colleagues and friends, dear members of the Academy. Thank you for inviting me once again to speak about urogenital reconstructions, focusing on a field I'm particularly fond of, urethral strictures. I'd also like to highlight the presence of Professor Bokun Gibod in the room, who honors me with his presence, as indeed about 20 years ago, when I was a medical student, he introduced me to this discipline. And then later, by the time I joined the department, he had already left. So urethral strictures, an iconic pathology in urology with several advances made, especially over these last 20 years, which we'll try to list for you. I declare no conflict of interest. Indeed, in urogenital reconstruction, we have few conflicts of interest. We mainly use human tissue because synthetic tissues have never proven to be very effective in this type of surgery. Regarding the anatomy, it's important to provide a review because there's quite a bit of confusion in the literature. So at the present time, the terms are clear. The anterior urethra is the entire portion of the urethra surrounded by the corpus spongiosum. It's composed of three parts: the bulbar urethra, the penile urethra, and the meatus. And the posterior urethra is the area located above it. It's composed of the membranous urethra, the prostatic urethra, and the bladder neck. It's important to make this distinction right away because in the posterior urethra, obviously we have the sphincter systems. And so surgeries targeting this area will potentially affect continence. In any case, this will need to be discussed with the patients. Regarding the etiologies of the anterior urethra, not much to say. Most are from idiopathic causes for the time being. We haven't really identified them. In second place, we have iatrogenic causes. And it's true, one must confess that every urologist has likely been responsible for a urethral stricture, whether through a false passage, during a difficult catheterization, or through endoscopies, repeated ones. But indeed, iatrogenic causes and enderology are responsible for a certain number of urethral strictures. Traumatic causes, on the other hand, have rather decreased. Regarding anterior urethral trauma, it's mainly straddle falls that can be responsible for them. And then inflammatory causes are on the rise. Among inflammatory causes, we traditionally classified infectious causes like gonococcal infections and STIs, which have drastically decreased. But on the other hand, what's increasing is lichen, specifically lichen sclerosus, with a significant rise of lichen sclerosus in the population. In the anterior urethra, the most frequent locations are in the bulbar region, followed by the penile area and the meatus. As for the posterior urethra, it's simpler. We mainly have traumatic causes with severe trauma associated with pelvic fractures and iatrogenic causes, everything related to prostate treatment, namely post-treatment for benign prostatic hyperplasia or post-treatment for prostate cancer. I haven't included rare pediatric malformations like valves or others, which are truly exceptional. Regarding the diagnosis and evaluation, well, there's not much to say. The clinical signs are not very specific. They are signs of lower urinary tract obstruction with dysuria. It's perhaps important not to forget to ask the patient about their sexual function and especially their ejaculatory function, because unlike the obstructive syndrome of BPH, ejaculatory function is much more impaired in cases of stenosis, of urethral stenosis. As for the clinical exam, clinical examination of the genitals must always be performed, specifically to look for lichen. We don't have a specific questionnaire, so we don't have a specific PROM questionnaire. At the present time, although there are validated questionnaires in English that are being used, and of course we use uroflowmetry and post-void residual to evaluate the severity of the symptoms. Regarding the workup, we must perform two exams in the workup: the fibroscopy. Fibroscopy is important for confirming the diagnosis. In fact, we define a stenosis of the urethra for a diameter that is less than 16 French, which is the size of the endoscopes. However, it's not sufficient for planning the treatment of a urethral stenosis because we only see the distal part of the stenosis. We have no idea about the length, the severity of the narrowing, or the upstream urethra, so it's not enough. Once we've made the diagnosis of stenosis via fibroscopy, to be able to plan the patient's optimal treatment. And so we must, and this is really the big news, continue to perform VCUGs. VCUG, so retrograde avoiding cystoarthrography, an exam that has almost disappeared but still remains the gold standard in urology for screening urethral stenoses. Indeed, in recent years, we've moved from X-rays to CT scans, but not in urethral reconstruction, where the VQG really remains the gold standard, and it remains the gold standard, particularly because it is a dynamic examination. So we must sometimes remember we must know how to read them correctly. And indeed, there are two phases for this examination. A first phase, which is the retrograde phase, where we can assess the entire distal urethra, so all the urethra that is distal to the stenosis. And then a voiding phase, where we can assess the upstream urethra. We'll also have to know how to read and interpret these VCRs, because it's true that radiologists, even when they still have their protocols for performing these VCRs, have quite regularly lost the methods of interpretation. And so on the VQG, we can indeed know if we are more on the anterior urethra or on the posterior urethra. Particularly here, we can clearly see the sphincteric imprint. So we know that this stenosis is at the level of the bulbar urethra. Similarly here, we have a stenosis at the level of the bulbar or penobulbar urethra. Reading the VCUG also means knowing the limitations. These are images taken at a 3/4 angle. And so at the level of the bulbar urethra, well, we have an overlap of the obliquity of the bulbar urethra. And so the image we'll get on the voiding cystourethrogram is an image that's minimized compared to the actual size of the stenosis. We estimate on average that we need to increase the stenosis sizes measured on the voiding cystourethrogram by 2 to get the actual stenosis, which is not the case at the level of the penile urethra. However, on the penile urethra, it's important to pull well on the penis because it's an elastic organ to get the actual length of the stenosis at the level of the penile urethra. And then there are situations that are more complicated where we have to use certain tricks to do the retrograde phase, especially in these patients. So we can put in small catheters to inject the contrast medium, or else move on to even more ancestral techniques, which include intravenous urogram or suprapubic puncture, where we'll inject product and ask the patient to urinate in order to get a good image and correctly evaluate the length of the stenosis. In situations where we can't get a voiding phase, notably because the bladder neck remains closed, at that point we can consider explorations in the operating room, possibly in consultation under local anesthesia, with the passage of a fibroscope through the penis, but also through a suprapubic cystostomy if the patient previously had a suprapubic catheter. In terms of imaging innovations, as I was saying, not much. There's been some development in ultrasound. Ultrasound was interesting for the anterior urethra, notably to see if there's spongiofibrosis, so whether the spongy tissue around the stenosis is fibrosed. It can still be useful at the level of the meatus and the penile urethra. It's a bit less effective for the bulbar urethra. And then we have the development of MRI. MRI is good for the posterior urethra in particular, with MRI images that are quite good if you know how to optimize them correctly. So this is an MRI performed in T2 with the bladder full, the patient having been put on alpha blocker treatment so that the bladder neck is full. And then we concomitantly injected a xylocaine gel, which is good, which has a signal, which has an intense hyper signal on MRI. And so that still allows for some beautiful images. But I'll say it again, these aren't dynamic images. And so that's one of the limitations of this type of exam. There are some advances in dynamic CT scanning there, but they're not used at all in clinical practice at the moment. Now we're going to move on to what concerns us most, which is the treatments for these stenoses. So the ancestral treatment for urethral stenoses has always been dilation. We're going to try to unblock the pipe. It's been practiced since the dawn of time. Dilators can be found in the history of Egyptian medicine. We know that Epicurus, the philosopher, had very likely also suffered from urethral stenosis, and that dilation procedures or attempted dilations were performed. Multiple dilators have been described. Since the gonococcal epidemic in the 15th century, we started trying to dilate all patients with every type of instrument we could find. But unfortunately, this treatment is not very effective, at least, and we can question its legitimacy. The principle of this procedure is still quite uncertain. What is the goal ultimately? It's to try to widen the stricture without causing further trauma. and hoping that the widened area will be recolonized by healthy urothelial tissue, which is rarely the case. However, this treatment has remained popular and is still widely performed today. Why? Because on one hand, it's simple. It's very simple to perform, and it gives the illusion of effectiveness. I say illusion of effectiveness because indeed, if we perform a dilation, the one-day success rate is almost 100%. And so that's something that must be kept in mind, is whether we are offering a palliative treatment to the patient that will last a few days or weeks, which is, in my view, what self-dilations do, or are we going to try a curative treatment for this pathology? And so indeed, it gives an illusion of effectiveness, and it's problematic in the literature because as soon as follow-ups are short, success rates are very high for endoscopic treatments. But when we correctly analyze the data, especially long-term data, meaning at least 2 years, 2 or 3 years, then we see that the success rate is quite low. It's low and is estimated at about 30%. So endoscopic treatment, 30% success, which is quite rare to have such low success rates in surgery. We rarely offer surgeries with such low success rates. And we know there are risk factors for reduced success, especially if the stricture is long, if the stricture is more than 2 centimeters. At that point, endoscopic treatments are very ineffective. If the stricture is very tight, and even more so if there's complete obliteration, then the failure rate is very high. And the effectiveness of endoscopic treatment also depends on the location of the stricture. It works very poorly on the urethra, on the penile urethra, for example. We have rates, well, not everything should be discarded, though. If we have a stricture of less than 2 centimeters in the bulbar urethra, then when we perform a urethrotomy or a dilation, we have higher success rates, around 60%. So this is what exists in the current recommendations. If there's an anterior urethral stricture, we can offer endourethral treatments. If it's located at the meatus, then we can try a dilation. And if it fails, we must consider urethral reconstruction. In the penile urethra, no dilation because the effectiveness is very poor. And in the bulbar urethra, if the stricture is less than 2 centimeters, then we can offer endoscopic treatment. In the posterior urethra, things are a bit less defined, but overall, regardless of the location of the stricture in the posterior urethra, we do no more than 2 maximum attempts of endoscopic treatment before considering urethral reconstruction. Why don't we insist on endoscopic treatments? Because the more we do, the less it works. And that was published a long time ago. It works less, but are we actually harming the patient? Most likely, yes, because by repeatedly traumatizing the stenosteria, well, we're going to cause increasingly significant scarring phenomena and cause a lengthening of the stenosis and make it more complex. Indeed, this is a case that initially had a good evaluation, Visiog, on a mild stenosis in the bulbar urethra that would have responded well to urethroplasty treatment. And 10 years later, while the patient only had dilations, stent placement, and so on, we have a much more complicated stenosis, meaning that there's already a complete disappearance of the urethral lumen in some areas, and the stenosis has moved up to the membranous urethra. And so the reconstructions, as I said before, since it affects the membranous urethra, there's a risk to continence, to urinary continence. So we shouldn't persist with endoscopic treatments if they fail, but rather offer urethral reconstruction more quickly. We've tried everything with dilation, so we shouldn't, in practice, there's no treatment that has shown superiority of one over the other. So we can use a cold blade, we can use a laser, we can do dilations, we can use a number of instruments to perform this urethrotomy, but no technique is more effective than another. The catheter size 2, the classic insert a size 20 Charrière catheter and leave it for 3 weeks, it won't recur. We also know that's false. There's no point in using large catheter sizes after a urethrotomy. It doesn't improve the outcome, and the duration of catheterization doesn't improve the outcome either. So there's no point in leaving a urinary catheter for more than 72 hours after a urethrotomy, except in special cases like massive urethroragia or something else. Performing self-dilations after urethrotomy isn't effective either. That's been well tested and well demonstrated. So really, what you have to understand about dilation is that it's a palliative treatment that leaves the urethra in a pathological state. but it doesn't allow the stenosis to be cured. And then we mustn't forget the complications related to these self-dilations and endoscopic treatments, which are frequent, over 50%, and are sometimes poorly tolerated by patients. When they have to do self-dilations at home, it causes pain and bleeding. It also affects the genital and sexual sphere. And as we saw earlier, it worsens the stenosis. Yet we still see these patients coming for consultations who've had, 8 urethrotomies, 100 consultations for dilations, and that still happens. The question also arises because they say, yes, it's the first treatment that should be done. It's simple, it's easy. Sometimes it can be done under local anesthesia. Right. But the reality is that from a medico-economic standpoint, I think a urethroplasty costs less than 8 urethrotomies and 100 consultations with the urologist without even curing the disease. And so at some point, you're going to have to replace the pipe rather than just unclogging it. Now, I'm not a plumber, but I think that's a pretty good analogy. New developments in endoscopic treatment, because there are always some. Currently, it's what we call balloon dilation. So we have the company Optilumen, which has marketed its device. So it's a dilation balloon for the stricture. I think balloon dilation is a good idea because it's less traumatic ultimately than urethrotomies, where sometimes the blades, since they're never changed, well, the blade doesn't cut. And so we end up doing more of a traumatic dilation. Here, at least, it's more precise for performing a dilation of the stricture. The other benefit is that these balloons are coated with paclitaxel, which is an anti-proliferative drug that would at least limit the recurrence of the stricture. They have rates slightly higher, more around 60 to 70% effectiveness. So we still need to give it some time before confirming things. For now, they only have an indication for bulbourethral strictures, and we already see that in clinical practice. It's used for all types of strictures. So, it's probably an advancement, but it must be used for the right indications. Because I'll remind you that balloon dilation, it's not new, right? It had already been introduced in 1822 by Ducamp, who also had the idea of putting at the end of a catheter. At the time, right? It was animal intestine to dilate at the level of the stricture. So Optilum maybe, but I don't think it's going to treat all strictures anyway. So as you've understood, we're now moving on to the curative treatment of urethral strictures, which is reconstructive surgery. And so for about 20 years now, and especially since 2020, there's clearly been a shift in the scenario for managing urethral strictures. Everyone agrees on this. And the techniques have also, many techniques have been described, and the techniques have become more refined to know which surgery for which type of patient. There have been recommendations too. So there were the EAU recommendations published in 2021, and they did an update in 2024. Similarly, there were the AUA publications, so the American Urological Association. And then we also made our own, right, which came out at the same time as the EAUs. So the French recommendations on the management of urethral strictures. This year, there's also the AFU report, which is on this very topic. So there you go. Centers have started saying that indeed the treatment for a urethral stricture, it was open surgery. Why? Well, mainly because the success rates are much higher than the success rates for dilations. The long-term success rates for urethroplasties are 70 to 95%, depending on the type of stricture. There are prerequisites before performing a urethroplasty. The first prerequisite is a fairly new concept, which is urethral rest. This means that for the stenosis phenomenon to be complete, there must be no intraurethral manipulation for a period of 2 months before it can be evaluated and operated on. This means that for a patient with a catheter, it must be removed and a suprapubic catheter possibly placed, but a 2-month period without any endourethral procedure is necessary so that the scarring process is nearly complete and the pathological area can be clearly identified during surgery. The choice of urethroplasty will depend on various criteria. Currently, we have 3 main criteria. Mainly, it will be the location of the stenosis and also the length of the stenosis. And then it will be the appearance of the stenosed part of the urethra, whether there is a residual lumen, whether the residual mucosa is altered by lichen or prosthetic material, whether there is spongiofibrosis, and checking the tissue if we are in a radiated area for the posterior urethra or otherwise. So these are things that will be taken into account to decide on the surgery to be performed. So now we are going to talk about anterior urethral reconstructions with the different techniques that can be used. So overall, there are 5 main families of techniques. There's the classic excision anastomosis technique. So excision anastomosis with or without transection, we will see the subtlety. There are enlargement techniques with free grafts. There are mixed techniques that combine the first 2 I mentioned. Then there are the more historical techniques, which involve 2-stage replacement or staged urethroplasty. And we must never forget urethral stomata, which also provide great service to patients. Regarding excision anastomosis techniques, we must mention Felix Guyon at an academy session with the AFU, because indeed he and 2 other surgeons presented this technique at the French Congress of Surgery in 1892, even before the Urological Society was founded. He presented the end-to-end urethroplasty technique for stenosis in the bulbar urethra. Currently, this technique remains a standard treatment, even though we now try to avoid transecting the corpus spongiosum. It is very effective for stenosis in the bulbar urethra, whether the urethral mucosa is usable or not. We limit its use for penile stenosis because it can obviously cause penile curvature postoperatively. Currently, what is more conventional is to use the same excision anastomosis technique, but instead of removing all layers of the urethra, we try to remove only the urethral mucosa while preserving the corpus spongiosum. Why? Because the urethra and the corpus spongiosum have terminal vascularization, so we try to preserve the bulbar and urethral arteries, which limits the rate of postoperative erectile dysfunction and also limits ischemia in the urethroplasty area. And so these are the techniques that have been developed. So the first, well, there's always a slight 4-year discrepancy between the 2 authors, either Jordan or Andrich and Mundy. It was the London team who proposed this type of technique for vascular preservation during urethroplasties. And they published high success rates, similar to excision and primary anastomosis techniques, with very likely, in fact, slightly fewer complications regarding the sexual and genital sphere. Next, we'll move on to augmentation urethroplasties with free grafts. Again, a major innovation. The first was performed by Professor Kirill Mikhailovich, who was Ukrainian in 1902. And so he performed the first urethroplasty using a buccal mucosa graft. It was a very good idea, but unfortunately, this idea was somewhat lost. Since in the 1960s, we started performing urethroplasties using only skin. And so buccal mucosa was used very little, whereas now it's truly the gold standard. And so for about 40 years, let's say, from 1960 until the early 2000s, urethroplasties were performed more with skin than with buccal mucosa. And currently, we know that skin urethroplasty results are not as good as those with buccal mucosa grafts. And we've learned several things. Firstly, because skin is more sensitive to the acidic pH of urine, lichenification is also possible in the skin. And then for a certain period, unfortunately, we also did urethroplasties with hair-bearing skin. And so we know we shouldn't do those anymore nowadays due to severe patient complications with stones and infections and chronic infections. So now it's really the buccal mucosa that has become the tissue of choice for urethral reconstructions. It was repopularized notably by Barbegli, an Italian urological surgeon in the early 2000s. So the buccal mucosa, indeed, it's a very good tissue for reconstructing the urethra for various reasons. It's a tissue that's naturally moist, it's thick, it resists infections well, there's a low shrinkage rate and a high take rate. So regarding the buccal mucosa, we can harvest from several sites. We can go to the cheek, which is called the jugal mucosa, or the tongue as well. Initially, it was thought we could harvest from the lip. Technically, it's possible, but indeed complications are much higher, notably with smile deformities. So complications for jugal or lingual mucosa grafts are, for their part, much lower, with complications under 5%. So for the jugal mucosa, we harvest here from the inner surface of the cheek, being careful of Stenson's duct. The width is almost always the same. When we want to make 20 French urethras, well, we generally take a width of 2.5 centimeters, and then the length depends on the length of the stricture. Obviously, you can leave it open or closed. I tend to close all surgical areas. I think it's more reasonable. But indeed, some ENT specialists leave it open, or other urological surgeons may leave the area open. In any case, it heals without much difficulty. At the lingual level, it's also possible. The harvest is a little less wide, the tissue a little thinner, but it's feasible. You just have to properly identify Wharton's duct, but it's also possible. Finally, if we take both cheeks and both sides of the tongue, we still have a lot of length to reconstruct a urethra. We get to about 20 centimeters in length. So in any case, we can perform buccal mucosa urethroplasties, perform buccal mucosa urethroplasty redo procedures. It's truly a tissue that is well suited for this reconstruction. Then once we've taken the graft, we can position it in different ways along the urethra. Everything has been tried. So we can position it at the dorsal level of the urethra, meaning we freed the entire urethra. And then we position it here at the dorsal level. This is what's most commonly done at the present time. Why? Because opposite, we have the corpora cavernosa, which are good nourishing tissues. Since we're going to fix the graft onto a nourishing tissue so it can be neovascularized, well, dorsal positioning seems more appropriate. But it has also been proposed laterally or ventrally. There are also different ways to access it. We can do an inlay. So an inlay means we'll dissect the urethra, incise the ventral side of the urethra, then the dorsal side of the urethra, and position the patch. Or we can do it as an onlay, which means we only incise the urethra once. And in certain situations, we can use mixed techniques where we'll position the patch here as a dorsal inlay because we'll operate through the urethra and put another one at the ventral level. So it's the dorsal inlay and ventral onlay. So these are studies to find out what reference centers are mainly using as a technique at the moment to perform anterior urethral repairs. So the main technique is augmentation urethroplasty with a buccal mucosa graft positioned as a dorsal onlay, as I showed you earlier. There are excision anastomosis techniques, obviously, which come in second place. And then there are mixed excision anastomosis techniques with a graft that are used. So here's another illustration of the dorsal onlay. So we have this patient who has a stricture in the bulbar urethra with a urethral lumen that is still usable. So we dissect the urethra using a catheter, or potentially we can also do it under fibroscopic control. We locate the strictured area, we'll incise, and then we'll place the buccal mucosa patch here that we'll have harvested during the same procedure from the mouth, and then suture the urethra to complete its repair. It can be done at the bulbar level. It can also be done at the level of the penile urethra or the meatus. Here we have the buccal mucosa, which has been harvested and fixed onto the corpora cavernosa. And then here we have the pathological urethra, which you can see here with its whitish appearance, which is placed, which is right here. And so this will allow for a good widening of the urethra at this specific point. And then there are mixed techniques where we combine both methods, so excisions with augmentations as illustrated here. Here we have the stenotic zone. We're going to perform an excision of the stenotic zone. And finally, upstream and downstream, there's always a part that's still a bit narrowed, and we augment it further with a buccal mucosa graft, as shown in the photo here. Regarding the operative setup, these are my standard procedures, just to show you a few surgical images. Standard lithotomy position. I secure the scrotum with staples to keep it well tensioned. We insert a guide wire that will pass through the stricture, and then a size 20 French catheter as a reference. We make the incision. I use surgical loops to operate. I truly believe that in reconstructive surgery, the use of loops and image magnification is vital. We perform fine sutures, and honestly, using these devices optimizes the quality of the stitching. So we go around the urethra, exposing it using vessel loops. We incise the stenotic area of the urethra. I place PDS sutures to clearly see the urethral lumen. And here we see the stenotic zone along with this area here. The appearance of the upstream urethra, which isn't stenos, but is metaplastic. And currently, several publications have shown that we must treat the metaplastic zones located upstream of the strictures, because otherwise it's a risk factor for recurrence. Now, for the stenotic zone, we perform a resection. So we only resect the mucosa. Here, we've preserved the corpus spongiosum. So we resect the mucosa, then we'll perform a mucomucosal suture. And then we're going to fix the buccal mucosa graft right here onto the corpus cavernosum. And then we'll do 2 continuous sutures on either side. This is the post-operative result of this technique at 3 months. I always check all urethroplasties using a flexible cystoscope. We also have a flexible fibroscope because we said the diagnosis was made when the urethra measured less than 16 French. So the fibroscope we have in consultation measures 17 French. So either we pass the fibroscope and the situation is satisfactory, or we can't pass it. At that point, we have to discuss other treatments. So here we easily pass the fibroscope. So at the top is the dorsal part. We see the buccal mucosa graft that was positioned. The area is quite wide. So here we are looking at a successful urethral reconstruction. There are no images like that. I've never seen one after urethrotomy or dilation. I've never seen this type of image. Afterwards, we still use somewhat more traditional techniques, which will be the 2-stage techniques. So these are techniques that were popularized notably by Beck Johansen in the 60s, where we laid it flat, let it heal, and then later remade a tube. So at present, we haven't moved too far away from this technique. It was also the BRCA technique in hypospedia surgery, except that now we perform an excision, let's say, of the entire stenosed area. So we excise the stenosed urethra, and then we apply the buccal mucosa here. We wait for the mucosa to take, well, so that it's well vascularized, that it has developed neovascularization. And then 6 months later, we perform a tubulization of the buccal mucosa graft that has taken well. We don't make a tube when we use grafts. So we've understood well that there needs to be tissue to nourish the graft. And so we no longer make a tube complete when using a graft, because we know that the area that will best vascularize the graft will be the corpora cavernosa, and any part not in contact, in fact, with this nourishing tissue will necrose. And so when we use grafts in reconstruction, we no longer make a whole tube. And then the last option, in case of multiple failures, we can always consider performing a perineal urethrostomy, a relatively simple surgery that provides great service to patients, especially when they have complex histories of urethral stenosis for years. So we obviously make the stoma above the area that is narrowed on the anterior urethra. Patients are continent, almost all are continent. When we perform a perineal urethrostomy, this option simply isn't possible for posterior urethral problems. The challenges were the other part of the presentation. Very clearly on the anterior urethra, things are well standardized. Even in case of failure of a first urethroplasty, the German team of Professor Fisch has clearly shown that another one should be done, because we had success rates that remained high after a second urethroplasty. The challenge for me at present, in any case, is post-hypospedia stenosis. And I work notably with Necker Hospital, Trousseau Hospital, for the management of these patients. There are a number of patients who, after hypospadias, repair surgeries, will develop complications, and complications that will require multiple interventions. When we have an adult patient with a hypospadias who presents a stenosis, very often, in fact, they present several problems. On one hand, there's the stenosis, but there can also be areas of fistulas, and there's a skin defect, and there can also be a curvature of the penis. So in this case, the decision-making algorithms are much more complicated. At present, none have been correctly published, because there are 3 to 4 parameters to take into account to achieve an optimal repair of the situation. So that is really, in my opinion, the current challenge. So for post-hypospadias, we'll have to manage the quality of the covering tissue. Here we see that it's extremely altered. This skin of the penile shaft is not going to be usable. So we'll have to think about, once we've done the urethroplasty, covering it correctly. The other parameters to evaluate are at the urethra level, width of the neourethra, location and diameter of the meatus, appearance and size of the glands, presence of hair or stones in the reconstructed urethra, associated urethrocoeli or fistula, and characteristics of the penis. including length and degree of curvature. So for urethroplasty as well, we can do either two-stage procedures or enlargements depending on the situation. And there's the curvature to manage. Curvature is managed in two ways. Either we classically do a Nesbit, so that won't impact the urethral surgeries because it will be performed on the opposite side of the urethral surgery. The downside is that it shortens the size of the penis. And we know that a certain number of hypospadias patients are ultimately considered at present within the intersex spectrum because they also have a small penis. And so this surgery is not going to be optimal. Otherwise, we do corporoplasties, so incisions at the level of the ventral side. We're going to put a graft to straighten the penis. The downside of this technique is that during the procedure, we're forced to have removed the entire urethra. And so that's going to add a surgical step. So here it's no longer a two-stage, it's at least a three-stage if there are no complications. So often a bit more than 3 stages, 3 or 4 stages. And then the skin coverage, as I showed you in the previous photos, right? Hypospadias, we know it's a deficit of the entire ventral side of the penis. So we'll have to find skin to finish closing the penis shaft after the urethral reconstruction. At present, what's quite popular is to use a scrotal flap that we're going to bring up to the side, to the ventral side of the penis. That's what we use the most at present. That's another illustration. So this is a patient who had a small penis and for whom we did a patch incision. Then 6 months later, so to correct the curvature, 6 months later, we did a buccal mucosa graft for him. And then the next step, since I haven't operated on him yet, will be to tubularize this buccal mucosa graft and then use a scrotal flap to cover the ventral side of the penis. So that's what happened with this patient. Here we have the scrotal flap at the end of the reconstruction, which was brought up to cover the entire ventral side of the penis. So much for anterior urethral strictures. We're going to move on to posterior urethral strictures now. The issue is a bit different because, as I mentioned, continence needs to be carefully assessed. And technically speaking, it's more complex. Accessing the posterior urethra, even though robotic surgery makes dissections a bit easier, is truly more difficult, managing posterior urethral strictures. So as I mentioned, there are two causes. There are causes related to pelvic fractures, and then there are causes related to the prostate. So regarding pelvic fractures, fortunately, with the decrease in road traffic accidents, we're less and less exposed to this type of situation. So these are major traumas, road traffic accidents involving a pelvic fracture. And ultimately, the term stricture isn't really appropriate. In fact, that's why in English, they don't call them strictures. It's actually more of a urethral distraction that occurs at the level of the urethra, of the membranous urethra, with a loss of continuity. Initially, endoscopic treatments were always proposed, specifically including realignments. Do we perform a urethral realignment? Will the urethra heal that way? Well, it's still being debated. There was, however, a randomized controlled trial that was released this year, and it stated that if we attempt a realignment, meaning we go in from above and below to try and see the light, it must be brief. So less than 30 minutes to an hour of surgery, because otherwise some people have insisted on realignments. There have been catastrophic situations, like this one. We see that ultimately they saw each other, the two fibroscopes saw each other, but they weren't actually in the urethra or at the neck. And so false passages are created. In any case, what's certain is that for these traumas, the initial phase is patient stabilization and managing orthopedic issues. Once they are stabilized, we can potentially consider a realignment. Otherwise, we wait 3 months, which is the average time allowed, especially since they need to be placed in the lithotomy position. But we wait 3 months before performing a urethral reconstruction on them. Reconstruction of the posterior urethra is primarily resection anastomosis. So as we showed you earlier for the urethra, for the bulbar spongy urethra, we mainly do resection anastomosis. However, there are technical maneuvers because we'll have to try to shorten the curve of the bulbomembranous urethra as much as possible to bring the urethra up. And so there are various maneuvers. The first maneuver is to have thoroughly freed the entire bulbar urethra up to the start of the penile urethra. The second maneuver is to have separated the corpora cavernosa to be able to pass between them. And the third maneuver is to perform a resection of the lower part of the symphysis This is now we primarily repair them via the perineal route. There were abdominoperineal routes performed with total symphycectomy, but they are more morbid. So now we only perform a resection of the lower part of the symphysis. We also have high success rates for this type of repair, between 85 and 97%. This is the literature. The risk of urinary incontinence is quite low. Ultimately, if one of the two sphincter systems works, either the neck or the membranous urethra, the risk of incontinence after urethroplasty is quite low. Erectile dysfunction rates are mainly linked to the trauma, not just the surgery, and are reported at around 34%. And now this is the last one, the really big topic, in my opinion, at least in terms of advances and challenges, which is posterior urethral reconstruction following surgical prostate treatments. Now, when it's just BPH treatments where the prostatic capsule is still present, things are fairly clear. We can perform bladder neck plasties, VY plasty or T plasty, which work relatively well and aren't overly technical. We now perform them mainly robotically, which allows for good access to the area, the surgical site. We perform a release that is ultimately similar to that of a radical prostatectomy. And then we perform a plasty. So in a Y shape, it's the most popular technique for the narrowed neck area. And then we advance the V here to restore a nice wide urethra. This technique works well. And as I said, we only touch the neck, not the membranous urethra. So we have a high success rate and a low risk of urinary incontinence, which is around 13%. So this is a fairly popular technique of moderate technicality, let's say, for experienced robotic surgeons. And then the big challenge now is really posterior urethral strictures after prostate cancer treatment. So obviously post-radical prostatectomy with anastomotic strictures. And furthermore, to improve, so to speak, the patient's life experience, we also tend to use radiation on the anastomosis in case of a PSA increase or recurrence. And afterwards, that sometimes leaves us in difficult situations with a devastated urethra. However, the solution isn't immediately cystostomy or cystectomy. We can consider urethral repairs in these patients and redo the anastomoses for these anastomotic strictures. Currently, in my experience, we perform them using a dual approach now, both robotic and perineal. We essentially follow the principles of the anastomotic resection we perform for the posterior urethra. Using the robot, we can thoroughly detach the entire retio space and get excellent access to the healthy residual bladder neck. And then suture the urethra. So we also do the urethral suture robotically, where we have better dexterity and it's easier to suture behind the symphysis. So in practice, these patients who come for consultation in these situations, like a patient who had a radical prostatectomy, then radiotherapy, who has a complete stricture and came in being both stenosed and incontinent. And so these are the patients we try to salvage through urethral reconstruction. So via the perineal route, we incise and perform an extensive release of the entire urethra, the entire bulbar urethra. Via the robotic route, we release the urethra and we're going to remove this necrotic area here. Often we combine this with an inferior symphycectomy to shorten the distance and then perform the suture robotically. It works well, and to prove it to you, this is a fibroscopy performed on the patient whose images are shown on the right. So we see the urethra is well repaired. There's no problem, except that any urologist will tell you there's something strange about this fibroscopy. There's no sphincter imprint at all. So the patient has a tube that is patent but not continent. So we haven't solved the entire problem. And the problem that follows will be the management of incontinence. And so for managing incontinence, obviously the only option is the placement of an artificial urinary sphincter. An artificial urinary sphincter, which is still technical to place because we have the bulbar urethra, which has changed in its anatomy. And here we can see very clearly that it no longer has the angulation seen on a normal vacuole. And so we're going to place these urinary sphincters in a transcavernous position in these patients. So that's the quote unquote current work we're doing. We've done about 30 patients on this, but not all have had the sphincter placement yet. And we're also waiting a bit to see the lifespan of these sphincters. That's it for the presentation. So the message really is that urethral strictures are treated by urethral reconstruction today. It took us a while to know which technique should be used. That's why the messages weren't always well received. But at the present time, there is a consensus. We know which technique, we know the indications better, we've understood better how to use tissues in reconstruction. And so that's really the most important message. And of course, we'll need to train, the younger ones who are also asking for training. So several things have been put in place, notably by the AFU. There are SHARUs meetings, which are discussions of complex urethral stricture cases at a national level. The AFU also entrusted us with this year's Congress report to clearly specify all possible treatments. And on a practical level, at Foch Hospital, we organized the penis surgery diploma and urethral surgery masterclasses. We've also developed at Foch Hospital MDT meetings for urethral surgery to discuss local cases in our department. Thank you. Thank you very much. I'll now hand over to Professor Colombel. Thank you very much for this excellent presentation, which allows for the management of all the urethral strictures we encounter. Well, it's true that I knew skin urethroplasties, which then completely disappeared. And urethrotomies, endoscopic treatments took over because it's easy and so on. And now there's work being done, and thank you for taking part in this work to implement these new urethroplasties using buccal mucosa and the management of strictures at the right time and with the right indication. So we don't end up, as we currently see, with patients who have a fibrosed, destroyed urethra. And it's all about training and information. And I think this very fine presentation from the Academy of Surgery will help with that. Now, a quick word about the French Association of Urology. Every year at its Congress, the French Congress of Urology, there's a report on a theme chosen by the board of directors. And so for the upcoming Congress in November, the theme was urethral stricture, of which François Xavier is one of the co-authors. And he tried to give us all the important messages regarding the treatment of this urethral stricture. And I'm very happy to moderate this AFU session as a former president of the French Association of Urology. Thank you very much. I'd also like to mention my co-reporters because I'm obviously not alone in writing this report for the AFU. We have the Lyon team with Dr. Morel-Jonel, the Lille team with Dr. Marcelli, and then the Marseille team with Professor Carcenti to lead this hour of the AFU Congress report. Professor Boncombeau, any comments? Our master, yes, well, that's why. That is to say that, in other words, there are too many patients who are dragged from dilation to urethrotomy, from dilation to urethrotomy. And I'm extremely surprised to see that at a time when we can train to do difficult robotic surgery that requires a long apprenticeship, we're not really interested in learning urethral surgery, which is a calm, seated, meticulous surgery, and which can give great satisfaction, but also setbacks. The problem is that functional surgery is a surgery that doesn't only yield successes, and you have to follow your failures, and it's sometimes painful to follow your failures. The second point I'd like to make is that urethral surgery is a field where there are a lot of trends
and very few randomized trials that allow for a choice between the different techniques. I believe it's never been shown by truly solid trials that surgery, that buccal mucosa enlargement was superior to enlargement using the foreskin. It's never been shown that dorsal implantation was superior to ventral implantation, which is technically relatively easier. And finally, we still have trouble agreeing on how to assess the results, which range from flowmetry, which we know is not reliable, to simple functional results, or even endoscopy, which ultimately remains the gold standard. In any case, congratulations.
Thank you very much. To answer perhaps quickly, of course, it's the definition of success. Definition of success, most papers say the absence of a new intervention. So that's not a satisfactory definition. We, with the European Group for Urethral Reconstruction, are currently doing a stricture factor. And so we've globally questioned the big names in urethral surgery across the world. We have about 60 people to see a bit what criteria they were using. Most likely several criteria are needed. Obviously clinical improvement, but a functional criterion is needed. So functional meaning flowmetry, a 10 milliliter increase in max flow or flow greater than 15 milliliters. And also an anatomical criterion. And it's very likely 3 criteria that are needed to correctly analyze the literature regarding randomized controlled trials. They indeed haven't taken place. The results where I said buccal mucosa was superior to the skin are based on meta-analyses. And then to add a bit more, we know very well that currently pediatric surgeons with extensive experience in urethral reconstruction for hypospadias continue to use preputial skin as a first choice for their urethral reconstruction. So there are still things to improve, but we'll get there.
Dr. Ronald Virag.
Yes, I would like to join Laurent in sincerely congratulating you on this very fine and impressive presentation, which very clearly and thoroughly shows and explains the whole problem in detail. You also alluded to the issue of erectile dysfunction that can occur after pelvic trauma, which is an important point to mention. They are common, as we know. You said 37%. I think it's even more. So I have 2 remarks. The first one and a question. What is the percentage of erectile dysfunction in penile urethral surgery? Well, anterior urethral surgery. The second thing is to know if there's still a trend, as Wilson had proposed, regarding prostatic urethral surgery after prostate cancer, to put in both implants at once, that is the one for incontinence and the one for erectile dysfunction, can be considered as a single combined procedure.
Thank you for these questions on erectile function. So regarding erectile function at the bulbar urethra level, first you should know there are recovery possibilities. So results must be evaluated 1 year to 18 months after surgery. We initially at 6 months, there are papers reporting a 10% rate of erectile dysfunction. However, with recovery after a year and a half, we're closer to 2 or 3% persistent erectile dysfunction. Actually, the issue with bulbar urethral surgeries involving transection is that I don't think erectile dysfunction is the best parameter because we have patients whose erectile function is preserved, but ultimately the gland's vascularization was compromised, leading to vasomotor issues, except we have no way to evaluate it. The IIEF questionnaires are not at all suited for assessing glands vasomotor disorders. So I think there's a bit of, well, we need to refine things to properly evaluate the genitosexual consequences of this surgery. Well, with non-transecting techniques, we have, well, relatively low rates of erectile dysfunction. It also depends, obviously, on the patient. A 30-year-old patient with a urethral stricture might experience it. On the other hand, a 60-year-old with cofactors of appreciated surgery. And then the second, only sutures that were recently done, the passage of the urethra inside the corpora cavernosa. So I'm for one, but well, maybe as I get older, I'm less hesitant about surgery, but I still have a few small reservations.
That seems quite wise, especially since these patients often respond very well to intracavernosal injections for their erections.
Dr. Fons.
Congratulations on this very comprehensive presentation. I had a question regarding the graft. You didn't clearly see the percentage of graft necrosis or even post-scarring restenosis, for example.
Well, indeed, graft uptake can't really be evaluated without constant fibroscopy, so we don't have much data on that. However, I mentioned an 80% success rate. So 80% success means 20% failure. So 20% failure. The German team there showed that for those 20% failures, when you redo a urethroplasty, even with the same technique, you find success rates of 80% again. So basically their cohort was 1,000 patients. So they did 1,000 patients. A first urethroplasty, they're left with 200 patients. A second urethroplasty, There's still at 80% success. And so there's roughly 40 patients left in a situation, let's say well, not marginal, but more difficult to manage. And there you go. And we can do a perineal urethrostomy too. We can redo it, right? And you, sir, since we're judging well, how many urethroplasties have you performed? You have to be persistent in urethral reconstruction surgery. And how many urethroplasties have you already done on the same patient?
How many urethroplasties have I done?
On the same patient?
Oh, I must have gone. Actually, the problem is recurrent bulbar urethral strictures or extensive bulbopenile strictures. And I think we must know when to accept falling back on perineal urethrostomy, because there comes a point where you have to stop. So there you have it. And I believe that's truly important. It's true that this is something that is often overlooked, but many patients are very relieved by a permanent perineal urethrostomy, given their previous history, which has often been painful and very disappointing. I think there's one thing, fortunately, that has completely disappeared, and that's endourethral prostheses, which had their heyday 40 years ago. And they required many hours of surgery to remove them and then repair the residual strictures. Fortunately, this has completely disappeared.
Well, it has completely disappeared, although there are occasional breakthroughs, but indeed there's no place for permanent stents in these strictures. We still have patients on our hands who have had this type of treatment. So most of the time, first of all, it didn't cure the stricture. The other problem is that we have the mesh that has, migrated into the spongiosum. And so these are quite difficult situations. We perform mandatory 2-stage surgeries for these patients.
A question via video link from Dr. Moret.
Yes, hello. Hello, congratulations on this presentation. I just have a question regarding the use of the robot, since, as you know, we are completely revising the nomenclature of medical procedures. I don't know if Francois Richard is there. We're working a lot on robot-assisted procedures. And so if I understood your point correctly, for the treatment of the posterior bulbar urethra, you recommend the use of the robot almost systematically. That is, in nearly every applicable case.
I think the indication is still limited. It's the posterior urethra indeed, but it's just post-prostate treatment strictures, either at the bladder neck or at the anastomosis. We do indeed use the robot for this surgery because we find that it has simplified the suturing a bit for us. Afterwards, it's still, I think, a bit of a last resort activity, you know.
Okay.
Mr. Permanent Secretary, Professor Jouanet.
Yes, well, congratulations and thank you for your presentation. Now, I had always had the notion that it was a difficult surgery. And the question I wanted to ask you is, do all urologists perform urethroplasty, or is it ultimately one of the basic, well, not basic, but common procedures?
No, unfortunately, all urologists perform urethrotomies and dilations repeatedly. This surgery has a bad reputation, certainly, but I don't know exactly where it comes from because, as Mr. Bukongibo pointed out, in terms of performance, well, we're sitting comfortably on a chair, we're doing fine sutures, but then again, we're all surgeons. Any post-operative complications are not very high. There's no life-threatening risk to the patient. There's no risk of hitting a vessel like a renal vein or anything else. So I find it to be a rather calm surgery. Another surprising advantage is that there's no competition. We know there's a bit of competition, you know, among colleagues, but for urethral stricture, even in Paris, there's no competition. So that's another positive point. Now, I don't know if there's a peculiarity in France, but apart from a few Mohicans like Mr. Bokonjibard or other centers that continue to perform high volume urethroplasty for a long time, in France, it somewhat disappeared in the 90s. Probably in favor of minimally invasive surgery, which was more dynamic, where French surgeons really stood out on the international stage. But that's not at all the case in other countries. That is to say, in the countries surrounding us, we can take Italy, for example. In Italy, they continued to perform high volumes of urethroplasty without this period of interruption. Similarly, the Hamburg team I've mentioned several times from FITS, they have about 10 surgeons performing urethroplasties in their center. They treat 1,000 patients. So there you go. And likewise in England, Professor Mundy, who built a massive structure for urethral reconstruction. And currently, to illustrate the point, we have Kulkarni in India. He actually built a hospital for urethral surgery, performing 600 urethroplasties a year. So there, but it's true that in France, it kind of, well, it had bad press. It was a bit less interesting. But there you go. Our time has come. Professor Colombel.
Yes, a comment and an answer to your question. Indeed, as Laurent Bocon-Gibod was saying, it's an easy surgery. You're really set up quite comfortably. There are no particular difficulties with the dissection. We do fine suturing. It's surgery that doesn't bleed. And so any urologist should be able to perform this surgery. The problem is that since the 1990s, perhaps, we no longer see urethroplasty surgery in training departments. We no longer have training. Then came endoscopy, then came the introduction of new and innovative technologies for stone surgery was significant. And then soon after, laparoscopic surgery arrived. So all of that took its place. And then perhaps another thing, Professor Murray is here to hear me. It's that the billing codes for urethral repair surgery are really not profitable at all for a hospital. It's not profitable at all.
Well, that's a point I don't share. No, it's actually urethral surgery is actually quite well coded at the moment.
It has improved, but regarding the techniques,
I mean, it's the equivalent code to a total nephrectomy. Honestly, I'd rather do three urethroplasties in my day than 3 laparoscopic nephrectomies, but the national healthcare budget is better for it.
Well, thank you very much, Dr. Maddock. Shall we applaud him again?